Hi, everyone. Thank you so much for joining us today. We're super excited to be here to talk to you about the comprehensive approach from planning to development with Jill and Danielle. Thank you both for joining us on this webinar today. Jill, would you like to do a quick intro and then we'll pass it on to Danielle?
Sure. Well, good morning, everyone. Thank you for attending. We appreciate that. I am Jill Worley-Shook. I have worked in and around the medical equipment planning, procurement, and logistics for the better part of 30 years. I've jumped around a lot over that time, getting experience on the consulting side, the vendor side, the provider side, and also the software provider side. I've been with Northern Arizona Healthcare just under 3 years. I came up to Flagstaff in support of the full replacement of a 50-year-old hospital. Unfortunately, that subsequently failed through a community referendum, so our team has had to pivot into more of a renovation mode, capital replacement, and optimization of some of our existing spaces. NHS is the largest healthcare system in Northern Arizona. We are actually the second largest county in the country by service area. We cover 16% of the state of Arizona, and our coverage area runs from the California-Nevada border all the way over to the New Mexico border. We employ over 3,000 employees, and we service more than 700,000 people in that service region, including Grand Canyon tourism, as well as one of the Arizona State University populations. At our primary medical center here in Flagstaff, 25% of our patient population does come from tribal communities. So we have kind of unique demographics up here. We're actually one of the few healthcare systems probably that has 2 Navajo translators on payroll. Our 2 hospitals, our main flagships, Flagstaff and Verde Valley Medical Centers, have a combined capacity of 400 beds, and we're the only level 1 trauma center here north of Phoenix. We are finally unique in that we actually own our Guardian Air and Medical Transport Services, and we do hold 10 helicopters, a fixed wing plane, and 20 ambulances. So while we do support that level 1 trauma service line, when we do refer, we're sending patients down to the Phoenix metropolitan area, which is a 3-hour drive away. So I will hand it back to you, Diana.
Thank you. Danielle?
Good morning, everybody. My name is Danielle Mattox. I am the manager of equipment planning and projects at Sarasota Memorial Healthcare System. We are a community health care system based in Sarasota, Florida. It's on the West Coast, about an hour south of Tampa, which most people are familiar with. We have 2 hospitals in our system. One of them opened, our second hospital opened in 2021. And due to very large population growth, we've been growing at a very rapid pace for the last 5 or so years. I started with Sarasota Memorial almost 16 years ago and started in equipment planning about a year into that journey, so about 15 years ago. And in that time, have built many projects and had various sizes and scopes under that. The largest being that second hospital we opened in 2021, and we are now embarking on a journey to open a third hospital a little bit south of us, our main campus here. Total bed count at our 2 hospitals is around 1,300 currently, and will expand in 2028. And then we also employ about 10,500 employees across the Sarasota County area at our various outpatient and ambulatory centers, along with our hospitals.
Thank you. All right, for those that are attending, we do have a Q&A. So if you want to ask any questions as we are going through the conversation, please feel free to drop your question and we will get to it before we move on to other topics. So the first topic that I want to talk to you guys about is the lessons learned. Jill, what lessons do you have real examples of challenges that you encountered during the hospital equipment deployment and how your team was able to successfully navigate it?
Yes. I'm going to read off some of my notes here, but when I was hired at NAH to support our replacement hospital, interestingly, I was the first medical equipment planner ever brought onto staff here at Northern Arizona Healthcare. It was a new concept for them. Our small DNC team was small. We are continuing to grow. We're still relatively small and mighty, though. We have a senior and junior medical equipment planner. We have a singular project coordinator for furniture, signage, type 8 categories. We have an IT project planner on our team, a space program manager, a project accountant, and 2 project managers working under a director of facility program development. While we rely on external equipment planning firms for our external and larger projects, we had no systems in place other than eBuilder to manage our smaller and ever-expanding portfolio of upgrades, expansions, and acquisitions. Over the past few years, we've integrated 4 tower on the equipment planning side for both internal and external projects with our consulting partner, IMEG. And we've also piloted and successfully launched FreightTrain's fit-up into our activation workflow, and we have integrated that into our 4 tower planning database. Our procurement processes are a little disjointed, but they're integrated into eBuilder and Lawson, and we do have a dedicated capital buyer that functions out of supply chain. One of the greatest lessons we've learned in all of that is that our small rural organization was not equipped to support our increasing activity of our DNC team. We struggled to engage our internal stakeholders, working closely with biomed, engineering, field services, and supply chain. And in our effort to activate new clinic space in particular, it became painfully obvious that our standard operating procedures were not working for the project environment. We did partner with CME as an equipment distributor partner and also Beltman Logistics on move management. We also consolidated our warehousing and delivery, and that was a lifesaver for us on this particular clinic project, using both CME and Beltman to relocate existing assets. Through all of this, we learned that our operational counterparts honestly need to prioritize operational needs and not our project deliverables. So there was a conflicting priority across those stakeholders and those silos. Upon implementing both the software tools and these new partnerships, our second and third phases of that same clinic project were night and day in terms of the experience, both for our clinical stakeholders that were involved with it, but also the perspective that our leadership saw and how we managed effectively in that process. While Biomed did partner with us in the fit-up activation activities, they are active users in the system. Our warehouse partner was not. They chose to use their own internal mechanisms, but our ability to track those project activities real time and giving that information to our project manager really made it a tremendous success for us in subsequent phases of that project. So I'll give it back to you, Diana.
Yeah, thank you. Danielle, how about you? Do you have any lessons learned?
Yeah, I could probably talk all day about lessons learned, but I'm going to try to keep it a little bit brief. So kind of similar to what Diana has described, we've grown our equipment planning services that are in-house at Sarasota Memorial over time. When we first started working on projects back in 2010, we were using a lot of third parties, and we did not have a team or really the resources to be able to dedicate to it full time. We've grown that over time, and in 2018, we officially established an equipment planning department within our facility, and we started with a team of 3. We're thankfully now a team of 12 to support the growth and the initiatives that our system is undergoing. But when I think about some of the biggest lessons learned that we've had over time, I think to a period of time in 2021, when we were tasked with opening a 8-story oncology tower at our Sarasota, which was our main campus, and opening our new hospital down in Venice, which is about 45 minutes south. Construction on both projects was behind schedule. The opening dates were only 11 days apart, and they were not going to move. And we were having to get really creative with some of the solutions that we could implement in order to meet all of our project deadlines and be able to make sure that we were ultimately successful in seeing patients when planned. And so at the time, our organization made a decision to hire a transition planning team under one of the contractors in order to try to improve efficiency and make sure that both projects were transitioning on schedule. And then as a result of that, kind of started completing more regular walkthroughs on both projects. We were pulling the teams together more consistently and trying to fully coordinate what does a modified installation schedule look like, what are our plans going to be, and how are we going to ultimately be successful here. In addition to that was the first time we hired a third-party logistics company to provide resources for implementation of all of the FF&E on both of the project sites. Again, they were 45 minutes apart. It wasn't just walk across the street and make sure that we could do both. So we needed some extra resources to assist our internal limited resources that were being pulled in many directions and really needed to be freed up to oversee and manage the process rather than physically doing all of the steps of the processes. And it was during this season that we really were triggered into looking into softwares to better manage the details and the data behind the transition and implementation processes. Because we were in such a dynamic environment and it was changing hourly, not even daily, hourly at many times, that environment wasn't conducive to our very paper-based processes. And we weren't able to support the goals, and we didn't have the information we needed to really make the best decisions in real time. And so since that time, we've been able to implement several new software systems, and we've been able to leverage the ability to integrate those with one another to further improve our efficiency and our accuracy throughout the transition process.
Thank you for that. Tom, is there any questions on the Q&A?
There are two. So one is a question of, do either of you use Atania?
I feel like that may be a setup for me a little bit. I will confess that I am an Atania alumni. I spent 12 years of my career at Atania. And we all know, those of us that have worked with Atania, there have been some evolutions of leadership there and ownership and the commitment to development on that product line. And honestly, when I came to this organization, we had to be cost effective as well. And we found that the 4-tower solution was more cost efficient for what we needed and for the scale of projects that we need to utilize.
For us, we are former Atania users. We initially used Atania for about the first 3 years that we officially became a department and started using software. And in 2022, we transitioned to using 4-tower.
Gotcha. Let's see. So would either of you be willing to share your org structure with the equipment planners and how and where they fall? I assume that the question relates to third-party equipment planners and how you integrate those in the organization, but Amber, if that's not true, you can elaborate on that Q&A.
Yeah, I'm a little unclear on how to frame that question. I think we probably more so than Danielle, because she's got a larger team, we do rely on third-party planning firms. IMEG currently is the only external team that we use. I personally, as the medical equipment planner, do report up through development and construction. I know in some organizations, they actually report up through biomed and or IT. So that is a little unique, although I work very integrated with my biomed counterpart and do coordinate and collaborate with both biomed and supply chain on all capital procurement decision making. The management of our third-party planners, right now, for us, our IMEG relationship in both cases is as a subcontractor through the architect. So we did not contract them directly. And I will say that that's been a little bit of a frustration, particularly as I'm coming in and learning my own organization, trying to find that balance between where the responsibilities fall on IMEG versus where I need to provide assistance or, planning assistance, particularly with reuse allocation of existing assets. That continues to be a struggle for us to how to best integrate reuse assumptions into those databases when we're using someone like IMEG.
Got it. And then there was a follow-up about, do you see it as more cost effective to hire manpower to augment your team? You mentioned, I think, Jill, using consultants on larger projects and doing your smaller things internally. Maybe that's sort of the nature of the question.
Danielle, do you want to take a stab at this? You prefer to answer this one?
Sure. No, for us, we found it more cost effective because of the number of projects that we're doing. We're doing the vast majority of it in-house. And then where we're using the third-party consultants is to assist with resources on the areas that either my team doesn't have as much expertise to complete, or due to the cyclical nature of project schedules, we're using third-party resources to help us with the logistics of actual implementation and placing items on projects and those sorts of things. We do not use or very rarely use a third-party equipment planner. I'll kind of dovetail into kind of what our org structure is. I have 3 medical equipment planners who are employed by SMH that work under me. We have 2 project coordinators, and then we have 5 procurement specialists that support the entire life cycle of a project. And I just help make sure they have the tools and the resources they need to do what they need to do. We do report up through biomed, and then biomed reports up through supply chain. So we do have synergy there with everything that we're doing. But for us, when we have hired, so for example, a couple of years ago, we were in a kind of a staffing challenge time, and we were trying to hire a planner. We did bring on a third-party equipment planning company to assist us. But what we did is, instead of doing it for a certain scope of just a single project, we essentially had their team member working alongside of us on any project we needed them to work on, and working within 4Tower and doing what we needed to do. But essentially, we hired their staff member temporarily, rather than saying, we're going to hand this project off to you.
Gotcha. Okay. So there's another follow-up that we'll try to get to, but in the interest of time, let's move to the next question. Over to you, Diana.
All right, thank you. Danielle, regarding early planning, what is the biggest risk of delaying medical equipment planning into the later stages of hospital design, and how can your team mitigate these risks?
So the way I see it, the biggest risks are the change orders that cost time and a lot more money further along in the construction process than if they're planned from the beginning stages. So the earlier that the equipment planning team can be involved in the project, the better the outcome will be for the coordination of the equipment and the budget that's associated with providing that required equipment. So here at SMH, the equipment planning team has a seat at the table from the very beginning of schematic design, which allows us to have those conversations with the end users, to hear the requests early, and to coordinate with the design team all the details that are going to be required to meet those needs. And this also allows for early discussions regarding any budget constraints from either construction or FF&E in order to provide what the end user is asking for. And then that way we can create the opportunity to work collaboratively as the team and find the best solutions. Maybe the ideal state doesn't work, but maybe we can come up with something that does meet the budget requirements and what we can provide from a construction standpoint. And it hasn't always been this way at SMH. That ultimately changed over time because of prior lessons learned and the value that we were able to show by being present in those meetings from the start of design. So ultimately, there's a lot of value in it. And once leadership can see that value and can understand how much it really does improve collaboration and coordination, they'll welcome it.
Jill, do you have anything to add?
I would just add that with my organization, decision-making and approval processes can be a little protracted, a little extended out. And so when we forecast, I've had many examples of doing 2024 forecasting and then not planning to procure until 2025 or 2026. So, I think Danielle touched on this as, mitigating cost increases, dialing in purchase order commitments sooner than later to hold pricing, but also digging deeper in those early forecasting days. And really understanding what the needs are so that we can mitigate any scope creep later on of, oh, we didn't think about this, we didn't think about that. There's a tendency when you forecast to think 30,000 foot level, and then when you get into the project and you get into the weeds, you identify all these things that were not considered. So I think in these days and times with increasing shipping costs and cost escalation in general on our capital equipment, clearly understanding what the needs of the project are sooner than later and keeping those clinical stakeholders involved in the early planning and not making corporate assumptions.
Tom, is there any questions on the Q&A?
There are no questions at this point. Thanks.
Okay, thank you. All right, the next question regarding standardization. How does standardized workflows and tools for medical equipment planning and development improve efficiency? And what are the biggest challenges in achieving the standardization across projects?
That starts with me, correct?
Yes.
Okay. Yeah, I think one of the biggest challenges that my team has is we are a relatively small team, but our service region is very spread out. And we're doing a lot of activity at both our campuses. Our 2 main campuses are an hour and a half apart. So we spend a lot of time on the road. And also secondary to that, our little team is growing, and we're realizing very quickly that we didn't have good onboarding measures. So creating that consistency, that standardization, not only using the tools in a consistent manner, but having consistent workflows. We have 2 project managers who may have divergent ways of how they manage projects, and it's very disruptive to us when we're trying to support multiple projects across multiple project managers. So, coming back to the 4-tower and the fit up piece, that really has allowed us to streamline a lot of those processes. I touched on a little bit that we do use eBuilder for the budget forecasting piece as well. So just marrying up those tools, making sure that information is consistent and that our processes for how we push that information through and ultimately report it up through both our project managers and through our leadership is as consistent as possible. So it saves us time and makes us more efficient.
Danielle? Oh, you're on mute.
I don't know how that happened. Sorry about that. I completely agree with Jill. The standardization of the workflows is critical to our success. And similarly, we have project managers and leaders across the organization that are responsible for many different projects. And so having a consistency in the way that they receive data from us and the reports we provide them allows them to more easily engage with that data. Similarly for us, we have an in-house warehouse that is off-site from both of our hospital campuses, but that's where we store all of the project product. And so having the same documentation across all those projects and coordinating how products are being received in the warehouse and what those delivery requests for things coming out of the warehouse look like is critical to a successful implementation of a project. If we didn't have standardization there, we'd have a lot of room for error, not only on our side of, is it actually in the warehouse, but on the warehouse team side of preparing things and getting them ready for our third-party movers to come and pick them up and take them to a project site. So that allows us to really see the anomalies within a project, and it allows them to be handled more easily because we are so standardized in the rest of our processes. And I think the biggest challenge to this standardization really is the people. Different personalities and levels of experience with projects and what the software systems are drive them to have different ideas on how things should be done. And so we've really found success in encouraging our team to be involved in the establishment of processes as we've implemented new softwares and new workflows, and that allows them to really buy in and adhere to those processes once they're implemented. And then once they're consistent, we can really learn from each other and create a consistent result regardless of who's working on a project and what that team member's natural tendencies may be.
Yeah, thank you. Tom, any questions on the Q&A?
There are, I think one or two of them were from the prior question, but a question is, do you expect your medical equipment planner to handle warehousing, procurement, and deployment when you hire a third party?
I will speak to my organization that with our partner, and I'll keep referring to IMEG because that at this point in time is the only consultant that we have been working with. In both of my cases with IMEG right now, their scope of services explicitly is only through a construction admin. We did exclude any procurement or activation responsibilities. To be honest, that's made it a little bit cleaner for us because of the integration needs between 4-tower and fit up. That allows us to have a clean separation with when something gets procured in 4-tower, we can then begin our activation and our expediting activities in the FreightTrain fit up piece. So that handoff of the data between IMEG and our organization is very critical. I literally just got a file handoff this past week on a project. And as the in-house equipment planner, I just find it problematic having worked as both a consultant and an in-house planner. It's very difficult when you're the third-party consultant to truly understand that organization, to understand their standards, to understand their pricing models. And so my organization is struggling with, when we do use those consultants, what is my responsibility as Jill to how much of that information am I communicating out to them and holding them accountable to, versus let them do the planning, do the preliminary forecasting. They're doing all the BIM modeling and the coordination with the architect, but then that data gets handed off to my team so we can begin validating pricing, consolidating distribution opportunities, warehousing opportunities, and we would manage that all in-house.
Okay. A follow-up to that is there medical equipment planning standardization? Danielle, maybe
Yeah, I might have Danielle speak to that since you have more than 2 equipment planners. I think you probably have worked towards that ideal better than my group has at this point.
Sure. So not only are we standardizing our processes, but we're very standardized in our equipment. And so kind of to what Jill was just speaking to, that was one of the biggest challenges we were finding when we were working with third parties, is that no one knows our standards like we do. And, you know, yes, they change and they evolve, but having to communicate that out every time and ask somebody else to implement that was challenging. And so for us, yes, we're extremely standardized. We have implemented another software that holds all of our equipment standards organization wide. And that's where all of our quotes organization wide come from. So it gives end users a visibility to everything that we consider a standard. And then we have a standards committee. So they have reviewed all standards that are currently established. And then if there is some reason why clinically we need to look at something else or implement something else, make a revision to a standard, we have a standards committee, which is all executive level leadership from our various hospitals and ambulatory. Our first physicians group is all represented there, and they review and vet any of those requests for changes to standards. And then when those are approved, we would implement those as well. But we do, we carry a lot of our standards forward from project to project, and we use that historical data that's in our softwares to really use as the baseline for most of our projects, so that then we're not starting from scratch every time. We're starting with a set of data that we just modify for each individual project and that specific need.
One last, and then I know we need to move on. Have either of you used FitUp for IT equipment, peripherals, etc.?
I will say that my team, we are under the DNC umbrella. We do have a dedicated IT project manager who coordinates all activities. So we have benefited from that, of actually having at least the desktop. We have not got into low voltage. There are some gray areas of what that PM manages and what they track in FitUp and or 4Tower versus what is tracked offline. Similar to my project coordinator, who we do not track furniture in the database, but other categories that a typical project coordinate would track do get tracked. And we have found that tremendously beneficial, because the coordination between a furniture project coordinator, the medical equipment planner, and the desktop computing, we are all heavily reliant on one another and coordinating that. And FitUp has really allowed us to work more seamlessly together through those processes.
We're also using, it's not my team specifically, I have a counterpart on the IT side at our organization, and he has project coordinators and team members that work under him. But we are putting all of our IT equipment, or they are putting all of their IT equipment into 4Tower and into in using FitUp to check off those items as they're installed as well.
Okay.
And
so
Diane, I'll just, and Tom, I'm sorry, let me just add one additional footnote, because I think that there was a question regarding peripherals as well. I will concede that there have been some struggles with that, because desktop computing, it does, is there a keyboard? Is there a mouse? Is there a badge swipe? Is there a barcode scanner? We have been working through and trying to really tighten up what I would consider option and accessory level details, so that when we plan that desktop computing, it's not just the computer, it's not just a workstation. My project manager is working very diligently towards standardizing different standard setups, but they are tracking it to that level of incremental detail with each individual component.
Okay, and real quick, I think this is quick, but 2 people have asked this question. Are either of your teams responsible for instruments or of reviewing preference cards for physicians?
I will say that's a relatively hard no for me. With a caveat that depending on the nature of the project, like I'm doing a renovation to a surgery center right now where there will be an increase in instrumentation. I'm also doing an endoscopy expansion as well with a lot of scopes. So we are carrying dollars in the package for me to fund those through the project, and we will ultimately issue the purchase orders. But we don't have the expertise within my planning team to actually dig into what are the components of that instrumentation tray. Where are we going to source it from? We would still defer back to the respective techs to provide us that information, but we would facilitate that procurement.
Same. So we carry the dollars for instrumentation and put allowances in our budget up front. But we expect the clinicians and the experts in the OR or procedural areas to tell us what instruments and trays they need and what containers and all of those sorts of things they'll require in order to be successful. And then we will take those lists and quote and procure them from there.
Perfect. Thank you.
All right. So the next question for Danielle regarding technology. What role do advanced software tools play in optimizing medical equipment procurement and deployment? And how can healthcare organizations assure seamless integration with these existing systems?
So I'll start by saying we found software tools to be invaluable in establishing our processes and optimizing efficiency for our team. We built this from scratch, and so we've learned over time, and as we found areas of inefficiency or areas that we need to improve, we've sought out vendors and partners to be able to help us in that process. But ultimately, they allow our teams to complete their responsibilities more efficiently and accurately. And I don't need as many people to accomplish the same tasks because I have softwares to build in that efficiency. So one example of an optimized process is our utilization for fit up and tracking installation of FF&E in our project. Our old process was the good old printed room by room paper on the door, taped, and then manually marking off everything as we were placing in the room. But we were finding that inevitably the painters or the other trades would come and take away our papers or move them somewhere, and all of our so-called data of what we had accomplished was gone as a result. And so FitUp has really helped us to be able to take that process electronic and check things off there, report issues, things like that we were kind of struggling with a more paper and manual process with previously. And then we also didn't have to worry about who else is working in the area and how will their work impact our progress on our responsibilities. We've also really enjoyed the collaboration with talking to other users and understanding how do they use the same software tools. And sometimes it's very similar, sometimes it's different. As I'm sure you're probably hearing today as Jill and I talk about the ways we are using very similar and in often cases the same software systems. And it's been critical to our success to learn from others and know how these softwares can really help us accomplish what is in front of us. When we're talking to a new vendor, early on in discussions, we're discussing integrations and what our ideal state of the utilization of a software looks like. So we can learn, is that something somebody else is already doing? Or is this an opportunity for us to work together and create something new that nobody else is doing? We've done both with multiple vendors. And some examples of the integrations we currently have established, we have a requisition creation process that's established between 4Tower, our equipment planning software, and PeopleSoft, our procurement software. We have equipment list data that's going from 4Tower to FitUp. And then actually in the example of that requisition creation process, we've done that now twice. We did do that with Atania when we previously used that, and we're now doing it with 4Tower as well. I think the key to success in all of this is bringing the right resources to the table that have the technical know-how and are able to get you kind of that end result planned up front so that you know that where you're headed is going to meet the business needs and truly provide what you think it will. We found that most of the companies we've worked with have been very open to our ideas and worked with us. But you have to know and understand your own processes and your own workflows inside and out. Because if you don't, the tools don't really do anything to help you unless you can actually fully utilize them and implement them in a way that actually creates access to data, new workflows, efficiencies, gives your resources the break that they need in order to actually be successful.
Jill, do you have anything?
Yeah, two points I just wanted to add to that. One technology aspect that I want to mention through FreightTrain FitUp, they have a mechanism called the FragNet, which is basically the integration of the FitUp activation detail to your project floor plans. That also has been a tremendous opportunity. I had mentioned a clinic project that we did recently, and we literally had 6 corridors that were identical in setup. And being able to navigate via the floor plan and being able to identify, okay, I had a mid-mark table that had a pendant issue. which room was it in? I can quickly go back to that fragnet, go back to that room, and be able to navigate, just, being able to move around the building and being able to correlate your activation activities. Because I will tell you, by the end of the day, your brain doesn't remember which corridor you're in or where you're going. And so it was really helpful. And I did mention earlier that furniture is one category that we do not track through for tower. We here at NAH have a sole source contract with a furniture distributor called Goodman's out of Phoenix. They will coordinate directly with our architect on the drawings. So they completely bypass all of our traditional equipment planning processes. But what's nice about that is that with the fragnet, when they provide us that final floor plan, we can now overlay the Goodman's floor plan back on top of our equipment placements in the fragnet. And now we can, again, begin coordinating. If I'm setting a mid-mark table in a room, I understand what its relationship is to the guest chairs that are also coming into that room via the furniture distributor. So that's been a tremendous opportunity for us to really coordinate those various categories. The other footnote I want to mention is the real-time tracking on the job site. To Danielle's point, when we did our first activation, we did use door sheets because I just wanted it as a backup. But they do get lost. And in that particular project, we did an activation in the fall, but we did not do the relocation of the active center until 4 or 5 months later. And at that point, we had lost sheets. And so there was a disconnect of using old school door sheets. So the real-time activation is important, but you got to make sure you have Wi-Fi in the building, because literally the week that we were activating, the contractor had pulled his Wi-Fi out the week prior. And my IT folks said, well, the department's not moving till next spring. We weren't going to activate Wi-Fi for 4 more months. And now we were dead in the water. So technology is great, but you need to make sure that the infrastructure is there. And in job sites, it's always a challenge to make sure we have functional Wi-Fi to do the work out in the field. But it is helpful to do it real time and not have to go back at the end of the day and say, what did I do in corridor B? What did I do in corridor E? So those 2 pieces were tremendous to our team.
Great. We do have a couple questions, and I'm sensitive to time, but a couple of them are related. Do you have upper leadership's buy-in to get all departments on board using the various software tools?
I will speak to that first, because Danielle's going to outshine me on this one, I'm sure. We've only implemented FitUp in a couple of smaller scale projects, and that is an area of struggle that I will confess that for the most part, other than our biomed stakeholders who are actually checking in that they've done the biomed check and tagged the equipment, we don't have our warehousing partner is not in there. Beyond our DNC project manager, we don't have access granted to senior leadership. We still use a more traditional monthly reporting mechanism to report out to senior leadership where we're at with the progress of the projects. That will continue to be an opportunity for us to try to better integrate some of these partners back into the system.
For us, our senior leadership isn't utilizing the platforms or the various softwares we have. We have the ability to show them anything they want, and they do receive regular updates from us. But they fully bought into the concept of getting these different software tools in our hands because they saw the value in them. And I talked earlier about that kind of transition period in 2021 that was really challenging, that set us on a journey to look for what could we do better. And it was honestly senior leadership coming to us at certain times asking for information that we simply couldn't provide. And so when we were able to show them how these tools could better equip us to be able to give those answers, it was a lot easier to make the case for it because of that.
Great. And then we had a question and this is maybe not a quick answer, but can you quantify your cost and time savings either from a project or an annual basis for using these tools?
Danielle, do you want to speak to that?
It's tough to give it an actual number, but what I would say is I always look at it as it's offsetting additional resources I would need. I have to hire more people if I can't create more efficient processes. And I can't expect these people to be able to do the size of projects that I'm asking them to do and to do it well if I haven't equipped them with tools. And so some of that is a soft cost that I really can't put a number on. We have in the past, as we've looked at these different softwares, kind of said, okay, if we didn't have this software, how many bodies do I have to throw at this activity to really stay on top of it and make sure that we were able to continue doing what we needed to do with with the growth that we've been experiencing. Some of that is throwing a dart at the wall because our project volume we're typically 25 to 30 projects at any given time, and those are various sizes and scopes, but so it's a little hard, but we try. But that's, for example, the quoting software that we implemented, and we just went live with that last year, was purely our organization is growing, and I can only pull so many quotes in a day. So if I can put those tools at their fingertips and I can let end users have direct conversations with vendors and have a more efficient process, then I don't have to hire as many procurement specialists to pull those quotes all day, every day. And so that's really what often it comes down to, the resources that I would have to hire if I didn't have it.
Got it.
And Tom, I will add to that. One of the challenges that we have, particularly here at our main campus up here in Flagstaff in northern Arizona, we're a small rural town. We have a very low population. We have a housing crisis. We've got limited housing, and we have a very high cost of living. So hiring people into the organization is not cost effective for us. It's hard to bring people up who can afford to live, at the salaries that we have available. So we, are forced to utilize a lot of resources out of the Metro Phoenix area. Our warehouse consolidation has to occur out of Phoenix because we simply don't have warehouses large enough up here in the region to support the activity that we're doing. So while we can't quantify what it is costing us, it's really about cost avoidance for us because we don't have enough volume and activity to justify our own warehouse. So we have to use warehouses on an ad hoc basis. And that in and of itself is the cost savings for us by not having to make full-time or permanent investments in that infrastructure. As we all know, projects are very cyclical. So our needs are very incremental. So we're only bringing in those resources and paying for them when we need them.
Got it. Okay. There's a few more, but let's go to the next question. And then if we have time, we'll get caught up on all of them. If not, we'll follow up after the webinar.
Sounds good. All right, Jill. So you mentioned that you have consultants like IMEG, Beltman. So when do you think that hospitals should consider bringing in those third-party consultants for equipment planning and logistics, and why? And what key factors should be evaluated when selecting those consultants?
I think there's a lot of variables that go into play. You can't narrow it down to any one particular yes/no diagram, basically. But I think really understanding your benchmarks for your sizing and your complexity. How large is the project? One of the things we're struggling with our architectural partners is the BIM modeling. That's a very important part of the design process now. We do not have in-house resources. So if the architect elects to not use a third-party equipment consultant, while we can generate equipment books and we can generate that technical information, that coordination effort, if there is not a third-party consultant on the planning side, that falls back on the architect. So it almost becomes the architect's decision of, do I want to do all these equipment placements for this, 6OR ASC, or do I want my consultant to come in and do that coordination? But it's also a function of what are the capacities and the aptitudes of your team. I know for my organization, we're doing everything from linear accelerator replacements to, MOB clinic spaces. There's a wide spectrum of technology. In my Atenia days, I used to say, we have to be knowledgeable in over 3,000 categories, but we're generally an expert in none. So we need to really look at each individual project and identify what is the technical expertise that is needed. Do we have it in-house? If not, maybe we need to lean on those third-party consultants.
Danielle?
I think I talked a little bit about how we use third parties. So I think what I would add here is that when you're looking to hire a third-party consultant, understanding what the scope of work is and what the expectations of them are and doing that early and very clearly helps drastically in the long run to accomplish your goals and to get from them what you need to get from them. So, what are the project deliverables? What are the timeframes? Are we expecting them to come on site? Are they going to be able to do what we're asking them remotely? All of those are crucial expectations to understand up front so that we know we have an accurate cost estimate and we have the scope dialed into what we're going to need. And then one other thing for us here at SMH, we're really big on establishing partnerships with our vendors instead of just having very transactional relationships. So often that means that when it does come time to select a third-party consultant to do something or some scope of work that we have deemed we can't handle for a various number of reasons, we're going to call those partners, and we're going to that we've worked with before, that we have established relationships with, which also helps us to be able to ensure we're on the same page and our expectations are being met. And how are we planning for the cost? Because they're often vendors we've worked with in the past or have come highly recommended to us from other partners that we have.
Tom, is there any questions on the Q&A regarding this
Not
topic?
on this topic.
All right. So Danielle, regarding stakeholder engagement, how can project teams ensure that the key stakeholders, including clinical staff, supply chain teams, and construction managers, stay aligned throughout the equipment planning and deployment process?
So often during the planning process, that responsibility ends up falling on my team, because we are often the ones that are involved in many of the project meetings and hear firsthand updates or changes on how that's going to impact FF&E. And then we're going back and working with those end users to verify how those construction changes might impact the equipment that we're planning. We do have a sign-off process that our end users participate in, both for the architectural documents and our final equipment lists that support those final documents. So if there's ever a change, we work directly with them and take responsibility for coordinating any FF&E revisions between the internal end users and the design teams to make sure everything's fully coordinated. And then a little later in the process, here at SMH, we often implement 2 sets of meetings across all of our projects to assist with the alignment as we get closer to completion. So the first thing we do is we implement meetings with the construction managers a couple of months ahead of starting our FF&E deployment, so that we can fully coordinate all the details: truck schedules, path of egress, building and elevator access, critical work activities, other things of that nature, where, you can't just assume I can use this door, I can use the new loading dock, I can, I'm going to have a paved driveway. All of those things we can't assume. And so although our efforts to coordinate all of that upfront aren't going to be perfect, having a way to collaborate together and make sure everybody's on the same page pay significant dividends later when we're oftentimes the schedules are a little tighter towards the end and tensions might be a little bit higher, but we have that regular routine of talking with them and are able to be more successful because of that. And then the second thing we do is we implement a recurring touch base meeting that includes all of the internal key stakeholders involved in transitioning a project from construction to opening day. So those specific team members involved would change on a project by project basis. But if there's a team that's critical to opening a new project or turning over a new project, they're on the call. They're hearing from every other group. What are the challenges that we're facing? What are the updates on activities that are happening in the building? Does one department's activities impact another's? What are our priorities for completion? And ultimately, when are we going live? When's the grand opening? When are those key dates that we really have to have everything complete by? And there are many departments that are impacted by a new project like that. And in order for all of us to be successful, we have to collaborate and we have to be able to share our information.
Jill?
I think Danielle covered that very well. I will just touch on and reiterate that I think the regular communication, the regular schedule updates are really important. As I mentioned before, our board only meets once a quarter, so getting formal decisions on projects after they've been scoped can sometimes be delayed. So I think just having that courtesy of keeping your clinical stakeholders apprised, this is why we're not moving forward. This is what we're waiting for. This is our next milestone. But also something that Danielle mentioned to me in an earlier planning session is documenting decisions. Here in my organization, because of the nature of our region, we unfortunately do have a lot of turnover. So your decision maker who made the decision may not be your decision maker who is there on activation day. So being able to document how did we get from this decision to this, and who made that decision and how. And I think as a general perception we all kind of deal with as planners is when you get to the final activation and the final install, there's always this perception of, why did you make that decision for me? There's this perception that DNC is making all these global decisions, and it's very far from the truth. I think one of our most important roles is to facilitate the decision making and facilitating the best decision to accommodate your clinical stakeholders. So I think just documenting that, whether it's a simple sign off or an approval email of, yes, I agree, this is what we're going to order, so that there aren't those questions or those concerns at the end. And I think we talked earlier to change management and ultimately to change orders. being able to document, we agreed to only 12. Why do you now want 14? We signed off on 14. So, document, document, document. It's always kind of the necessary evil. We always feel like it's kind of a CYA, but I think it's important to document those decisions throughout that process.
Thank you. Tom, is there any other questions on the chat?
Well, I think that, yes, there are questions. There's some from previous questions. So I think if we're done with the moderated material, I do have some questions. So can Danielle elaborate on what folks are involved in the touch-based meetings, especially from the department/end user side?
Sure. So we have, it varies by project, but for example, we are getting ready to go live with a research institute. And so right now it's my team, it's the construction office team, it's the IT team, and their various project managers across, network and security and all of those sorts of areas. It is the key end users. So depending on project, the end users have different level of involvement versus the leadership over that project itself. And so it's those key leaders over those specific areas. And then it's the contractor and any key subcontractors that we have specific duties. A couple months ago, we opened a freestanding ER. That meeting was much larger because there's a lot more moving parts and pieces to opening a freestanding ER. And so, pharmacy, lab, all of the registration and EMS coordination and the various people that are doing transfers and all of those sorts of things, they were all included as well. So it really does depend on the project scope and what's needed. But the key to all of it is that it's IT, FF&E, construction, the contractor, all of the key people who are really kind of rushing towards the end goal of a project and making sure it's ready for those end users to take over.
Thank you. So there was a question for both, which is how large are your teams?
What was it? How large are your teams?
Yes.
So for mine, we're a team of 12. I have 3 planners, 2 coordinators, and then I have 5 procurement specialists. 2 of those focus operationally on the day-to-day procurement of capital and furniture, capital and routine equipment and furniture, I should say. And then 3 of those support nothing but projects and the procurement associated with that. And then I have an administrative assistant.
And my mix is much smaller. We have 2 medical equipment planners, 2 project managers, a single space program manager, a single IT program manager, and a single project coordinator. And then we have a dedicated project accountant reporting under 2 directors.
Thank you.
I would say our team has grown drastic. We were a team of 3 in 2018, to give you an idea. So we have grown drastically in the last few years because of the project volume we have.
Yeah.
Thank you. Do your teams get involved in operational activation, training, et cetera? And have you used FitUp for activating and commissioning?
I can take that first. We do not. We have other people within the organization that kind of oversee the training, the simulations, all of those sorts of things. So we support them in what their needs might be and make sure we're out of their way when those activities come, but we do not oversee the actual activities themselves.
And we are similar, Tom. We have a PMO, a project management office. They report up through the same senior leader as does DNC, but we do a handoff. So any applications, any training, any operational activation and commissioning activities do occur there. I will add a footnote that we do have a dedicated facility licensing expert who is on our DNC team, and they kind of bridge that relationship between the DNC physical activation of the building and the handoff over to PMO for operational readiness.
Got it. Thank you. Let's see. So are your teams required to track and report their time and tasks per project? And if so, what tools do you use?
Ours is a very simplistic process. While we don't track every singular hour, we do have a workflow that we call recharge, which means we actually forecast as a function of our project budget a recharge of our time and hours back to individual projects. So on a monthly basis, we will report out to our senior lead what percentage of our project time needs to be allocated against particular projects. And that is only for projects of $1 million or more.
Okay.
We do not capitalize our team, so we do not track our hours or what time is spent on which projects. None of it is capitalized, unless the only time we capitalize any of our labor is associated with if there was like a really tight project schedule where I had to incur a bunch of overtime or unexpected labor costs, then we would charge that to the project. But my general office functioning day-to-day is not capitalized.
Got it. So there was a question about how many projects your teams are working on at a time. I think Danielle mentioned 20 to 25. Maybe confirm that. And then Jill.
I would say ours is probably the same, while I would suspect they're probably smaller in scale. We do collaborate with our operational folks. So routine capital replacement, i.e. we've got a ton of our imaging devices that I had been forecasting for replacement for our replacement hospital. Now that is delayed, once they do make those final agreements, once the capital is approved, it will be handed back to D&C for the actual activation management and the replacement of that capital.
Got it. Thank you. Let's see. So do either of you reference a multi-year medical equipment replacement forecast, including routine as well as project-based needs? If so, what tools do you use for that forecast?
I will say for this organization, when I came on board 3 years ago, I was a little shocked that we were not doing longer term forecasting. It really was year to year to year. I will say, like most organizations prior to COVID, money was not actually an issue in capital procurement. And in recent years, we've seen a significant crunch in that. So we are slowly moving into that mode of having a 3 to 5 year forecast. Obviously, I work very closely with my biomed and supply chain capital program counterpart so that we can collaboratively forecast what I'm forecasting with future projects against what they're forecasting for routine replacement.
Similarly, so we do a 5-year capital replacement plan here and capital strategic plan. So I report up to the director of biomed and technology assessment. So he really handles most of that routine projection, but we do try to work together to make sure that any project purchases that we expect to make can then be aligned with any capital routine replacement so that we can consolidate that volume and negotiate better pricing as a result of the overall capital spend and not just what we're doing in projects.
Got it. Okay, so there's time for one more question, and if you've asked a question either on the chat or the Q&A that we don't get to, we'll try to follow up afterwards. But it was a two-parter. How much footage do you manage, and what department does equipment fall into? Is it design and construction, supply chain, whichever?
Yeah, and I'd have to defer to my project managers. Honestly, I don't know what our collective square footage is. And I apologize, Tom. The second part of that question
is, are you what department, what group, what organization does your group report up to?
We have a VP of development and construction that we report up through, and he's part of the senior leadership team.
Gotcha.
I also don't know the square footage number. It's a lot. It's, anywhere from a full hospital, which is hundreds of thousands of square feet, all the way down to a small physician office that's maybe 3,000 square feet. So our collective, I'm not sure. I could probably pull the numbers if somebody wants to follow up after. And then we report up through supply chain. So I report to biomed reports to supply chain.
Got it. Thank you. Okay, well, we're out of time for questions. Diana, I will turn it back to you.
Yeah, so thank you so much, everybody, for attending today's webinar. We do have another webinar coming up in July. We will send out the link to register. This is going to be with Maggie DeMattis from Houston Methodist and Timothy Menz for Northwell Health. So stay tuned to register. And again, thank you so much for attending. Danielle and Jill, thank you so much for being our panel today. We really appreciate it.
Thank you for having us.
Thanks, everyone.
Thank you.